Today's module is on the neurologic exam, and I will be focusing especially on the motor exam, but I will also discuss briefly the sensory and reflex exams. This is a very important part of how we approach diagnoses in order to get an accurate answer within the exam room. It's so important that I will separately look at the upper and lower extremities in terms of a detailed neurologic exam. Some of the broad things I want to emphasize here: what are the benefits of a good neurologic exam? Well, first of all, it's often not done well by a number of our peers, and if you just develop a good, rigorous system, you'll find that you'll pick up diagnoses so much more than you would have before. Secondly, it is important to really focus on being rigorous and systematic. Be complete early on with your first few thousand patients, and then later you can take some shortcuts based on your clinical understanding of the situation. In other words, experience will allow you to shortcut some of what you do rigorously, but that takes really quite a few patients to get there. You're also going to want to understand whether weakness that you encounter during the exam is from something neurologic, typically painless, or from a musculoskeletal problem. So for example, if a patient has pain with activation of the quadriceps and they've had a knee problem or knee surgery, that's probably not neurologic. It's probably due to the fact that when you activate the quadriceps, there's pain in the knee and they reflexively don't want to give full strength. Neurologic weakness, by contrast, is something that is painless to test on a patient, and that will help you with your differential diagnosis as you try to look for the source of weakness on physical exam. The basics for the motor exam: we're going to use a scheme that was developed after the Second World War, where we rate patient strength from 0 to 5. And I'll talk about that more when we get in the exam room, 5 being the strong or normal strength, and 0 being no strength at all, paralysis. One thing I want to emphasize is that sometimes if you look, for example, at some physical therapy notes, they will rate a shoulder abductor as having only 3 out of 5 strength. That's actually grossly abnormal strength. It's consistent with an incomplete spinal cord injury, and it's probably overly rating the weakness. On the other hand, for example, a number of surgeons will often say there's normal strength, and in fact, it's not normal if you do a careful exam. So really you want to develop these skills that allow you to grade between 0, paralysis, and normal strength 5. And again, we'll talk about that more in the exam room. One thing I want to emphasize is 4 out of 5 it's not like getting a B on a test. 4 out of 5 strength is in fact real weakness. Most of my patients, when they have weakness, it is at the 4 out of 5 level. And that will help us very much in terms of understanding the patient's underlying diagnoses. Another thing I want to emphasize is we will often go from proximal to distal. So in the upper extremity, we'll work on the shoulders and then move out to the elbows, the wrists, and finally the fingers and the intrinsic muscles of the hand. And I would say that when you do the exam, you want to give yourself a mechanical advantage when you're trying to detect subtle weakness. The classic thing is testing tricep strength on a patient. If you have the patient's arm out like this and you try to bring them into flexion or have them activate their triceps, it's fairly easy for them to do that. If you have the elbow in flexion, they have a lot of difficulty doing that, and you have a more sensitive test. And finally, I want to say that you learn from your patients. I've developed over 30 years by examining thousands of patients ways of detecting subtle weakness on physical exam, and I've become better at what I do as a result. I'll just touch on the sensory and reflex exams. As you may know, sensory modalities include light touch, pinprick, vibration sense, joint position sense, and temperature sense. In clinical practice, such as mine, usually we're looking at light touch and pinprick. If we suspect a neurologic deficit, we will use pinprick. If we don't really suspect neurologic deficit, say a rotator cuff tendinitis, we'll typically just do light touch. If I really need to get more advanced, I will look at temperature and vibration sense, etc., and I can demonstrate that in the exam room. Finally, reflexes, I would say, they're really kind of overrated. By the time someone has reflex abnormalities, usually we know the diagnosis. And I'll talk about that more again when we get in the exam room. An important thing to understand here is that I'm not really talking about reflexes for upper motor neuron problems, such as stroke or spinal cord injury. Then I think reflexes are actually quite a bit more important. I'm really talking about peripheral nervous system problems such as radiculopathy or pinched nerve, sciatica, that sort of thing. And finally, I generally reserve mental status, cranial nerve, coordination testing for very specific circumstances. For example, in the TBI, traumatic brain injury patient, we will look at mental status testing. Or if we think there's a stroke or something like that, we might look at coordination testing. But generally, in my common practice of peripheral nervous system problems and musculoskeletal problems, I don't have to invoke coordination testing and that sort of thing. Okay, let's go to the exam room. And again, we will break this up into the upper body and the lower body. So for the lower extremity neurologic exam, again, the major focus will be on the motor exam. In the upper extremity motor exam module, I discussed already the 0 to 5 muscle grading scheme that we typically use. So I won't get into that again here. I'll just show the mechanics of how we do the lower body or lower extremity neurologic motor exam. I do need, Jennifer, for you to remove your shoes if you could for me. And while she's doing that, I'll discuss a few other broad principles. One is that, especially for the lower extremity, there's often subtle weakness of hip muscles, and that's not necessarily neurologic weakness. It can come along with deconditioning, hip arthritis, a variety of conditions. And so I would not read into those too much, but distal muscle weakness often has a more neurologic basis. Jennifer, if you can lie on your back for me. Typically what I look for, and you can integrate this into your musculoskeletal exam, so I would be looking at hip flexor weakness. So maybe I'll hold the leg up, I do the straight leg raise maneuver, and then I'll ask you to hold the arm up, hold the leg up here, hold the leg and be as strong as you can. And that's hip flexor strength. And then knee extensor strength, push straight, push as hard as you can. And typically we cannot overcome that with the patient on their back like that. The muscle's just too strong. So I'll show a more sensitive way once I have Jennifer stand up. And then really useful muscles neurologically are these muscles in the foot. The ankle dorsiflexion, bringing the ankle up, hold it up. So if someone has a foot drop, that would be weak. But even more important is, I'm gonna take your sock off here. Extensor hallucis longus, EHL. I call that the poor man's MRI scan. This little guy here, it's sort of put on the human body to help us detect subtle neurologic weakness. You have the patient hold the big toe up towards you, hold it, hold it, hold it, and that should be strong. If it's weak, and it's often subtly weak, it goes with lumbosacral radiculopathy or sciatica, such as from a disc herniation. So if you're trying to sort out if someone has a lumbar joint injury versus true radiculopathy with nerve root injury, this poor man's MRI scan, EHL, a forgotten muscle by and large, is extremely important. Again, hold it up as hard as you can. That's a 5. If it's a 4, it might be just a little bit weak like that. Again, mostly missed by many providers. You're always comparing the right and the left side. One other thing you could do, especially for sports injuries, you could have them push out here, ankle eversion. It tends not to be that useful for neurologic testing, but for some ankle injuries it is important. Can you go on your stomach now? And I've mentioned this in other modules, but I'll mention it again. For the hamstrings or knee flexors, you really need to have the patient positioned like this. If you have them sitting and you're just trying to test the hamstrings, you're not going to get the level of sensitivity you need. Hold the leg up and be as strong as you can. And that's intact knee flexor strength. And then I'd have the patient lie on your side if you could. And I would have them a little bit forward, and this is hip abduction. Very important muscle because this is often weak with a large number of medical conditions, including things like patellofemoral pain syndrome, which we discuss elsewhere. Hold it up, be as strong as you can. And that's intact. You want them a little bit pointed forward so they don't substitute another muscle called TFL. Okay, let's have you stand up, Jennifer. I'm just going to illustrate a few other things. Unfortunately, you have one sock on and one off, but maybe that'll work. I want to show ankle plantar flexion. Turns out ankle plantar flexion, or pushing the foot up, is difficult for me to test with you lying on your back. So we have to have you do it more extremely with, I'll pretend I'm a wall, so you use me for balance. On one foot, you're supposed to do 10 ankle push-ups. 3, 4, and you count that out, and you compare right and left. And typically, if they have weakness of ankle plantar flexion, for example, from an S1 radiculopathy, that will be weak. Patients will be surprised. You could go a little further and have them try to hop, but that can be really difficult. And then for the quadriceps, remember I mentioned those are difficult to test also with the patient on their back or supine. I'm going to bring in this stool, have you have a seat here, and let's say either side, but we'll have the patient try to come off on one leg, so you can't use your arms, and just push off. That's extremely hard for quadriceps muscle to do. And that's the way you can really tease out muscle weakness, for example, with an L3 or L4 radiculopathy. Typically in my exam rooms, I'll even raise and lower the exam table so I can find the increment where they no longer can perform that on the affected side, but they can on the unaffected side. And then finally, I've talked about sensory and reflexes elsewhere for the upper body, but let's have you lie here. I'll just illustrate the reflexes with a reflex hammer. Ken, as I said elsewhere, you always have to have a good, big reflex hammer. You can't have a wimpy one. And I'll position myself here and bending the knee, try to relax the patient, and that's a good reflex. Again, reflexes are not as useful in my setting. You know, it's sort of a late finding, but if you suspect upper motor neuron problems, you know, such as a stroke or a spinal cord injury, they become more useful. Okay, thank you.